Um, oh, and then could someone put in the link to the CP Solvers feedback form in the chat, if possible?
I
So
can
the
do that
CP
right now.
Solvers have a feedback form just to basically help get some information about what's working well, or if you have any ideas or feedback. And I think this is just a great way to, help and have your ideas out there and everything. So we would really appreciate you filling out the form. And then I just wanted to do a brief reflection on Kirtan's case yesterday. I could not even hope to do it justice because it was an amazing case. It was a young female who had this past history of demyelinating lesions that were presumed to be ADAM, and then came in with these psychiatric changes, behavioral changes, hallucinations, and also some urinary and bowel changes. And it was a long discussion about what could be going on in this case. And then the imaging showed both gray and white matter involvement of both the brain and the spinal cord. And it ended up being actually two diagnoses, which kind of came about from just saying, like, why are there these behavioral changes and everything there? So it's a case of both anti-NMDA encephalitis and NMO. And so crazy case. But I did just want to talk a little bit about some of the causes of different white matter lesions, because that's not something I thought about a lot before. And it's something that can be quite a broad differential. So I was just looking at the Stat Pearls article on this, and it talks about how white matter lesions can be both vascular or non-vascular causes. And some of the big vascular causes are things like small vessel disease, atherosclerosis, migraine, amyloid angiopathy, CADASIL vasculitis, and then Tay-Sachs syndrome. But there's also a really wide non-vascular differential, like inflammatory lesions like multiple sclerosis, ADAM, NMO, spectrum disorders, infections, HIV, PMLE, neuroborreliosis, HSV, CMV, neurosyphilis, cryptococcal infection, Whipple's disease, SSPE, and then there's like toxic causes like alcohol abuse, carbon monoxide, intoxication, heroin and cocaine use, and then B12 and copper deficiency, porphyria, tumors like CNS lymphoma, traumatic causes like radiotherapy and post-concussive. And then in this case, we're talking about, since it was a younger patient, about could there be some sort of hereditary or genetic component. So especially if it's a younger presentation, you would think about things like lysosomal storage diseases, things like peroxisomal disorders, like X-linked adrenoleukodystrophy, things like mitochondrial disorders. So we talked about, like, could this be a manifestation of MELAS, but there wasn't any like lactic acidosis or anything like that in this case, but that can sometimes be a mimicker, and then kind of other rare diseases too. So I definitely thought it's a very broad differential, and so that's just a reminder to keep things broad. So in this case, it looks like we have one discussant. Anyone else to discuss? Please. I'm not as good at silence as Jack is.
The reason I usually wear sweaters for virtual morning report is so that you can't see me sweating through the silence, because it also causes me a large amount of anxiety.
Sonia. Or Anisha. So Who wants to discuss? Awesome. Awesome. Well, it looks like Anusha is going to discuss as well. Oh, okay. Tanya said she was just agreeing about snail mail. So don't agree about snail mail or you might get volunteered to discuss. So does everyone want to introduce themselves?
I can go. I am Sharda. I am entering my 4th year in med school here at UCSF. I don't know what else you would like to know, but long-time listener. Nice to be here.
Awesome. Well, I'm so glad that you're discussing tonight. Do you want to team up with me?
Sounds great.
Awesome.
Hello, hi everyone. I was just grabbing my AirPods. Sorry for the delay. So I'm Anusha Chidadla. I'm PGY Internal Medicine resident. I'm going to pursue my HemOnc at Kansas University. Excited
Welcome,
to start the
Anusha.
case. Yeah. Hi.
Great to see you. So Anusha, you and I will team up for the case tonight. Anne-Marie and Sharda, do you want to take the first aliquot or the second aliquot?
I'll let Sharda decide.
I have no preference. I'm fine going first, just to get things started.
All right, so Anusha, you and I will then take the second and the fourth aliquot.
Sure.
Gurleen, take us away.
Yeah, I have it divided into 5 aliquots, but I can adjust as we go on and the discussion goes on. So the first aliquot, this is a 39-year-old male who presents with shortness of breath and hemoptisis for a couple of months. Describes that he's coughing up coin-sized amounts of blood multiple times every day. Can you hear? You can hear me, right? Okay. And sometimes it causes him to induce vomiting because of the hemoptisis. He also endorses orthopnea and nocturnal dyspnea, and his symptoms have progressively worsened since they started. And that's the end of the first aliquot.
Okay, so there's a lot here. I'm just writing stuff down as I go because that's how I think. So just to formulate this in a sentence for myself, this is someone who's a middle-aged man who's presenting with, for a couple of months, that's sort of on the borderline between subacute and chronic for me. And he's coming in with shortness of breath and hemoptisis. So I guess we could talk a little bit about the Dyspnea Pyramid as sort of a way of thinking through shortness of breath. So we can think about, I'm trying to remind myself as I'm talking through this. So we can think about cardiac causes, we can think about lung causes, and we can think about other causes. And the hemoptisis, coughing up blood, sounds really important to me. And it makes me think about something that's possibly primary in the lung. So that could be something like a malignancy, depending on what exposures this person might have, something like vasculitis, like Good Pastures. So something could be going on in the lungs, but I'm not letting go of the heart either because of the symptoms he's endorsing of orthopnea and nocturnal dyspnea, which really sound like heart failure symptoms. So I'm trying to sort of tie together this picture of someone who possibly has pulmonary edema maybe with coughing up blood. And so I guess what I would want to know is I definitely want to know a lot more of the social history, thinking about, could this person possibly have TB? Could this person possibly be having a malignancy? But I would want to know if he's been having any systemic symptoms like fever, weight loss. Those are my initial thoughts.
Oh my gosh, I did. I talked while muted again. This has been a recurring problem. I love that approach. That's such a good approach to have. I like how you said, let's look at the foreground, but try to layer on the background because that's going to affect it. So the immune status is going to affect it. So having those really good social history questions, looking into any past history that's there, because a differential would be very different in a patient who had HIV or exposures or had grown up in a different country, things like that. So that would definitely change a differential in addition to like anyone with congenital heart disease or something like that, that would change it. So I love that you layered on the background to the foreground. Then I also love that you said, okay, there's hemoptisis. So let's kind of focus on the big organs that could be at play, the heart or the lungs. Kind of thinking about hemoptisis, those are kind of the two big ones I think about. I always try to kind of go through a list just to make sure I don't miss anything. I actually saw this great schema today, actually, from Dr. Kristen Carroll from Northwestern that was posted. And so I'm like, hey, I'll just like pull this up and talk through it so I make sure I'm not missing anything. So watching out for mimics like GI bleeds or epistaxis, things like that. So asking about that because that can certainly mimic hemoptisis. And then someone who's having some vomiting too, you know, you just want to make sure that you're not missing that. And then you mentioned the lungs. So thinking about everything in the lungs from the upper airway, some sort of bronchitis, which is a very common cause, especially in young people, that the time course seems a little off. Bronchiectasis, malignancy, this would be usual in a 39-year-old, but certain types of malignancy can certainly present earlier. Some COPD, again, that would be a very young age unless there was like alpha-1 antitrypsin or something like that. But cystic fibrosis, that'd be a late presentation, but sometimes people can have late presentations, especially if there's more mild mutations, some sort of fistula. Foreign body, again, seems less likely. And then we'll go down to the parenchyma and think about, is there some sort of infection at play? The 3-month history makes me think if it's an infection, it's more indolent. So I'd be thinking about things like tuberculosis or maybe like an abscess that's just presenting really indolently, but then it's a little weird that we don't see any systemic symptoms. And then occasionally like fungal and parasitic things can present like this. And then again, malignancy, and then like all your room stuff that you mentioned about like being worried about DAH, things like that. So could there be some sort of ANCA vasculitis that can mimic malignancy, good pastures, lupus, things like that? And then cardiac, because we are getting some cardiac signal. So I love that you mentioned saying like, oh, there's orthopnea, maybe this is contributing. So could there be some sort of valvular pathology? You could think about like some sort of something congenital or rheumatic fever or endocarditis, like a subacute endocarditis at play, some sort of maybe constrictive etiology leading to pulmonary hypertension or other vascular malformation, like an AVM, something like that. And then also like, are the coags okay? Is there some sort of coagulopathy? So looking for bruising, other signs of bleeding, asking a good history about things like vaping and cocaine use. And then because this is not a female, we don't have to worry like about things like endometriosis. So there's a lot at play here and it's a huge differential. And so hopefully kind of the next aliquots are gonna give us some more history, but I'm kind of leaning towards a cardiac cause with the orthopnea, but there's certain things that can mimic it. Sometimes diaphragmatic things can mimic orthopnea, and definitely some more history is going to help.
Yeah, so the patient also endorsed chest pain and tightness during exertion with occasional palpitations. He reports bilateral upper abdominal pain for the past few weeks with decreased appetite. He's also been having chills and night sweats for the past couple of months, but no reported fever. In terms of other review of systems, he denies lower extremity edema, no weight change, no syncope, lightheadedness, or dizziness. He's had no recent travel and no sick exposures, does not follow with the PCP. He also says that he's been having 4 to 5 loose bowel movements per day of unknown duration. In terms of his past medical history, he had a recent dental abscess. He was seen at urgent care a week prior to presentation and was started on amoxicillin, which he's been taking. He has no other past medical history and no surgical history. In terms of his medications, he doesn't take any besides the amoxicillin that he's been taking just for the past couple of days. And for family history, he has no family history of heart disease, history of lung cancer in his grandfather and colon cancer in his father. For social history, he's not traveled outside of the country. He was incarcerated a year ago for a few weeks. Since then, he's been working as an aide for blind individuals. He's sexually active with 2 sexual partners in the last year, no history of sexually transmitted infections. I'll just slow down a little bit. Sorry. And in terms of other social history, he used to drink a pint of alcohol per day. He's recently cut down to 4 drinks a day. He's been smoking for the past 20 years, smokes 5 cigarettes daily, and he denies any recreational or IV drug use. That's the end of the second aliquot.
All right, Anusha, we've got I'll say a case that continues to become more and more complex as the information comes on. I'm very interested to hear how this new information is shifting the way you're thinking about things after that incredible discussion from Charlotte and Anne-Marie.
Sure. Firstly, I would like to ask 2 questions. I missed the sexual history, and is there any weight loss? No, right?
He denies any weight loss, no.
Okay. Sexual history, sexually active?
Yeah, I said, so he's sexually active with 2 partners in the last year, no history of previous sexually transmitted infections.
Okay, great. So there is a lot of information. I can go line by line and dissect it. So there is chest pain with exertion and bilateral upper abdominal pain for the past weeks and decreased appetite. So chest pain makes us think maybe it's something related to the chest. And in the chest, we have the cardiac source. Is it related to cardiac or is it related to lung? Whether the hemoptisis is secondary to the cardiac cause or whether the hemoptisis is secondary to the pulmonary cause. And given orthopnea and PND, it's more leaning towards the cardiac cause. However, cardiac and pulmonary can be related often. So it looks like, given, I'll come to that later, given that his chills and night sweats and also decreased appetite, makes us think that he has constitutional symptoms, even though he doesn't have fever. Not all patients should have a fever. Some patients who are immunocompromised tend not to mount a fever unless the infection is too worse. They won't mount a fever because their immunity is very compromised. So in these patients, maybe his immunity is not that great. That's why he did not mount a fever till now. So he has chills, night sweats, and appetite, which makes me think of systemic symptoms. So he's having some signs of systemic constitutional symptoms, basically. And then this has been going on for the past couple of months, which makes us think this might be an indolent infection, or it might be something indolent process going on over the last few months. So it's a subacute process that's been going on for the last few months. And obviously, with these symptoms of night sweats and also decreased appetite, we're always concerned about TB. And with these symptoms of hemoptisis as the main problem, we are always concerned about TB. So that's why we want to know about any recent travel or sick exposures. But interestingly, this patient has been in the prison or incarcerated for a while.
So most of the patients who are incarcerated, they are at risk for having TB. So you always have to keep in mind whenever you see a patient with incarceration and whenever you think about hemoptisis, because these patients are at risk for getting TB. And then his past medical history is pretty interesting because he had a dental abscess not long ago, within the last 1 week. That makes us think, is the dental abscess cause of anything like anything related to his symptoms? So we have to know whether he had recurrent dental abscess, because if the patient had recurrent dental abscess, then that may lead to infective endocarditis, which leads to septic emboli and having a hemoptisis like this. Or this dental abscess is only recent. So it's been very recent within the last 1 week. Is this something unrelated? Because the symptoms have been going on for almost 2 months or so, for a couple of months, but this dental abscess is in the last 1 week. It may point out towards his immunity. Maybe he's immunocompromised, that's why he has the dental abscess. Or it may also point out that if he has recurrent dental abscess, then it might be because of infective endocarditis or something like that, which may lead to septic emboli and cause lung abscess and cause this hemoptisis. But at the same time, why is he having orthopnea and PND? Infective endocarditis can always present with orthopnea and PND if it invades the valves. But if such patient will be hemodynamically unstable and will be more sick compared to what we are looking at this person. And then coming to his family history, his grandfather has lung cancer. So when I look at this, I always like to divide the diseases into MAID, which is like malignancy, A for autoimmune, and I for infections, and D for drugs. And the other thing is like I go by pathophysiology, like since it's the hemoptisis, then I go by organ, like cardiac or lung cause, or is it GI cause, which is causing him to have some vomiting, and it's presumed as coughing. Sometimes patients who has hematemesis, they doesn't differentiate between hematemesis or hemoptisis. And then so lung cancer history in the grandfather, that makes me think, okay, does he have any lung cancer? Because he's having these constitutional symptoms, but there is no weight loss. And we are not seeing that. And I'm mostly leaning towards infectious cause as of now, given his constitutional symptoms, and also given him being incarcerated. Maybe he has some kind of aspergillosis or some kind of a TB going on. Yeah, so 5 cigarettes for 20 years. So smoking is a risk factor for, again, lung cancer. And other important thing is if a patient has underlying lung disease in the past, they may have something like bronchiectasis and stuff. So that is one of the cause for having hemoptisis as well. But doesn't seem like he has any underlying lung diseases in the past. So with the information I have, like the incarceration and orthopnea, dyspnea, and the hemoptisis, everything, I'm leaning more towards an infectious cause, maybe like a TB or aspergillosis, or it may be infective endocarditis if he has any recurrent dental abscess.
That was brilliant, Anusha. I have nothing to add. Gurleen, I'll turn it back to you to continue on with the case. Phenomenal discussion.
Yeah, it's been such a great discussion. I'm learning so much by listening to you all. So I can move on to the vitals. His temperature was 35.7, blood pressure 102/70, heart rate 124, respiratory rate 24, satting 100% on room air. General appearance, he's alert and oriented and no acute distress. HE and T exam is normal. Atraumatic normocephalic. Cardiovascular exam, he's tachycardic, no murmurs, and there's jugular venous distension that's noted. Respiratory exam, his lungs are clear to auscultation, slightly diminished lung sounds in the left base. For the GI exam, he has some non-specific tenderness, slightly more in the upper quadrants, but otherwise no rebound, no rigidity, no other peritoneal signs, no focal deficits on neurologic exam, and he has no lower extremity edema and no other skin changes. I can move on after we're done writing the physical exam to some of the basic labs.
Doreen, could you just clarify? Did you say that there was jugular venous distension, or that
Yeah,
there was no jugular?
there was jugular venous distension.
Okay, thank you.
Yep, and neuro and extremities and skin exam were normal. So for the CBC, the white blood cell count was 8, hemoglobin 13.1, hematocrit 39.2, platelets 253, sodium of 131, potassium 3.6, chloride 102, bicarb 20, BUN 8, creatinine 0.96, albumin 3.8, total protein and calcium were normal, bilirubin was normal, alk phos 79, AST 49, ALT 42. And a urinalysis showed traced urine protein and ketones. Specific gravity was 1.029, negative nitrites, leukocyte esterase, negative white blood cells and red blood cells. PT was 13.3, INR 1.2. Troponin 0.05, and BNP was high at 1,239. CRP 9.6, which is slightly elevated, ESR 9, and procalcitonin 0.11. I was also going to give the initial chest X-ray and EKG in this aliquot, and then we can have the discussion. So the EKG showed sinus tachycardia and left atrial enlargement. Chest X-ray showed patchy bilateral interstitial opacities, suspicious for multifocal viral or atypical pneumonia, including COVID-19 pneumonia, with trace left-sided pleural effusion and mild cardiac enlargement. That's all the information I had for this aliquot. Sorry if I spoke too fast.
So I'm trying to wrap my head around this. Starting with the vital signs, he's breathing a little fast and his temperature is lower than I would expect. So that does make me worried. I know for older patients or people who can't mount a fever, you can be worried about people with a lower temperature sometimes being septic. But he doesn't sound from his general exam to be in acute distress or very ill. The other findings are the JVD and the decreased breath sounds. And then that coupled with the imaging findings of the left atrial enlargement and some sort of non-specific lung findings. I'm trying to put those two together. And I'm wondering if there could be some kind of pathology in the lungs or in the vessels that are sort of backing up to cause right-sided heart failure, although that wouldn't explain why he doesn't have edema. But I'm just trying to put the lung picture and the heart picture together. And then there's a sort of non-specific abdominal picture that I'm not quite sure how to tie in with this. And so that makes me wonder if it is an infection, could it be something, or could it be a process that's more systemic than just one infection in one particular spot? Or maybe it's referred pain. But I didn't want to forget about that, especially because we know that he's also having diarrhea. His white blood cell count is unremarkable, which sort of rules down infection for me a little bit. But again, I'm not sure with TB. I haven't seen any patients who have it, so I'm not sure if people don't necessarily mount a very impressive white count with an infection like that. But it is notable to me. And then his hemoglobin is low, not that surprising given that he has been coughing up blood and it's a normocytic anemia. So we're not worried about some sort of underlying iron deficiency or nutrient deficiency. In terms of his BNP, let's see. His bicarb was 20. So he is acidotic and he's hyperventilating to respond to that. Okay, and you don't have a VBG. So this is making me worried about him, just from a global perspective. Let's see. The urinalysis is not that revealing, but the BNP is high. And so I guess my question is there a process that is moving forward, and is it a primary process with the heart, or is the heart having a problem because of some other problem? Because I think it's pretty clear that there is something cardiac going on here, and this person probably does have heart failure. And if the person has left atrial enlargement, could that be because of a problem with the mitral valve? Could it be because of a problem with the ventricle? Or sorry, not the mitral valve, the tricuspid valve. Or sorry, I am mixing up my directions. It's late in the evening for me. Yeah, I think I'm rambling on at this point, but I feel like there's a picture here that I'm failing to put together, so I'll just put it there.
I love that systemic approach, how you just like went through everything and made sure like I've addressed everything, put it together, and then, said, how can I put this together? I quite honestly am stumped too. Kind of a no misdiagnosis and someone who has tachycardia and hemoptisis, of course, is PE, but the time frame just isn't right for that. And I honestly was a little surprised by the exam. We know that his heart is under strain because he's really tachycardic, he's tachypnic and everything. And I was actually kind of surprised by the borderline low temperature and then the exam that didn't tell us much. I thought I was going to hear a murmur. And endocarditis, at least in about 85% of cases, you will hear either a new or worsening murmur. So, that it's still on the table, but, we're not at least getting as much signal there, but we can't certainly not rule it out here. We do have the elevated JVD, which does at least narrow it to the heart has elevated pressures here. So we know there's some sort of pressure problem in the heart, and that maybe that is also affecting the lungs. And then I don't know if it could be affecting the liver as well, and maybe that's some of the tenderness, or there's something else going on. I think the difficulty I'm kind of battling here right now is I seem to have some like signal of inflammation, like the night sweats, the diarrhea, some other things. But then I look at the labs and there's not a lot of signal of inflammation on the labs. And so I'm trying to figure out how I can connect those two. And some of the ways that I would think about would be some sort of immunocompromising condition or atypical infection that doesn't present with, all the typical things. So I definitely want to look at the differential here, see if there's lymphopenia that could point to HIV. Still thinking about like tuberculosis or indolent things. And then also something like a malignancy that could present with this. And like when I think about malignancy in the heart, I think about, could it be some sort of valvular lesion? So could there be some sort of like atrial myxoma, lymphoma, sarcoma on the valve at play? Or could there be some sort of something surrounding the heart causing some sort of effusion that's causing the backup? But we don't really, other than the tachycardia, we don't hear like, we do have the elevated JVD, but we don't hear like diminished heart sounds or anything like that. But that's certainly still, something I'm thinking about. You can sometimes see low voltage EKG, but the lack of it doesn't rule out some sort of large pericardial effusion too. And then I'm still thinking about, could there be some sort of indolent infection there, or some sort of like merantic endocarditis, things like that, carcinoid syndrome, rheumatic fever. And so I think right now, like all that to say is I'm not sure. I'm still struggling to connect the chest x-ray findings with the like cardiac findings. I'm trying to figure out like, it doesn't really seem like TB, like the time course seems too indolent for a lot of bacterial infections, like, I think someone had mentioned Legionella, which certainly some of the symptoms, but the time course would seem very like long for that. And like a COVID, things like that. So I'm kind of struggling to connect them. I'm wondering about, is there some sort of tricuspid embolization or something at play here, or some sort of process connecting the two, or are we just seeing edema? So I'm definitely excited to hear more information.
Yeah, so some other information. So he was COVID, PCR was negative, hepatitis C was negative, HIV was negative, TSH was 2.94. A urine toxicology screen was done, which was positive for cocaine metabolites, negative otherwise. Ethanol was negative. An echocardiogram was done, which showed a left ventricular diastolic dimension that was dilated. Left ventricular systolic function was severely depressed with an ejection fraction of 25 to 30%. The right ventricle was dilated, and right ventricular systolic function was also depressed with biatrial dilatation, as well as moderate to severe mitral regurgitation and moderate tricuspid regurgitation. We also got a CT chest, abdomen, pelvis. For CT chest, there were centrally distributed peribronchial right lung-sided ground glass opacities that were more confluent at the right lung base, with some subpleural consolidation in the anterior right upper lobe. No cavitary lesions. The overall read of the CT chest was that it was nonspecific, could be pulmonary hemorrhage versus infectious versus inflammatory. That was the read from the radiologist. There was also some small dependent pleural effusions with mild mediastinal and right hilar lymphadenopathy. The CT scan also showed global cardiomyopathy, hepatomegaly, gallbladder wall thickening at 1.1 centimeters, with a small amount of right upper quadrant mesenteric and pelvic ascites. This is the end of the fourth aliquot, and then after this, I just have some additional lab work before I reveal the diagnosis.
All right, Anusha, I'll let you take it away again for what I'm sure is going to be another excellent discussion.
Okay, so that's a lot of information again. So I'm glad the COVID is negative, because I was a little worried. However, it's a subacute course, but COVID is tend to cause myocarditis and this kind of presentation very acutely in the first 2 weeks or 3 weeks, but not so late, like 2 months, couple of months. It's unusual. And Hep C, HIV are negative, that's good. And the other thing I wanted is an RPA to rule out like mycoplasma, because sometimes atypical viral infections can cause myocarditis, and at the same time they can cause this kind of presentation like cardiomyopathy from the myocarditis itself. But interestingly, we found that his urine tox screen is positive for cocaine metabolites. Cocaine is negative, or it's positive?
Cocaine was positive in the urine
Okay.
tox. Yeah.
Yeah. So cocaine itself can cause cardiomyopathy, and it's evident on his echocardiogram that he has cardiomyopathy, and that's the reason for his orthopnea and PND. Now we know like he has orthopnea and PND due to his cardiomyopathy. But what is the cause for the cardiomyopathy is the biggest thing, right? So it seems like he's not a very reliable historian, because he denied any with drug use, and sometimes it depends on the provider as well, how like how you approach and how you ask the patient about the drug history, because sometimes people may snort cocaine sometimes. So it's important to ask them about that. So here it looks like he has cocaine, and cocaine is one of the causes for non-ischemic cardiomyopathy, and it can also cause ischemic cardiomyopathy too by causing vasoconstriction of the cardiac vessels. So I'm thinking maybe is it cocaine-induced cardiomyopathy, which has caused him to go into the severe cardiomyopathy of EF of 25 to 30% in a young male, 39-year-old. Next is CT abdomen and pelvis. It showed peribronchial and ground glass opacities. So whenever I think about ground glass opacities, so ground glass opacities can be secondary to cardiac cause, like the pulmonary edema itself can present as ground glass opacities. Or the other thing is PJP, pneumocystis pneumonium, which can also present with ground glass opacities. Given him being cocaine user and previously incarcerated, is he immunocompromised? But HIV is negative though, right? So I'm not entirely sure if he's immunocompromised or not. But these ground glass opacities, I think, is likely from the pulmonary edema itself. And we know that global cardiomyopathy from the echocardiogram itself, and he has hepatomegaly. I'm not sure if it's like a congestive hepatopathy or congestive hepatomegaly. He might be having these kind of symptoms of heart failure for a while, and he might be having something like a congestive hepatopathy, which might be causing him to have this non-specific tenderness in the right upper quadrant too. And then ascites can be a sign of right heart failure. So I think ascites, pleural effusion, I think are secondary to the heart failure itself. I don't think it's a different process going on. So I'm just wondering what other tests Gurlin is going to give us. So maybe if we want to know about the ground glass opacities, then we can do some PJP. If we are still thinking it may be infectious because the CRP is elevated at 9.3, and CRP is an inflammatory marker. So is there something inflammation going on somewhere? If we want to know like some kind of infectious process or some inflammation going on somewhere, we can always order Fungitel and also like LDH and PJP. Those. But right now I'm leaning more towards cocaine-induced cardiomyopathy in this young individual, which is causing him to have heart failure signs and symptoms. But at the same time, I'm not entirely sure what the right upper lobe nodule is. Sorry, right lower lobe nodule is. And Gurleen, how big is the nodule? Can we biopsy?
There's a small solid non-calcified 4 millimeter right lower lobe nodule.
Yeah, so that's pretty small. So I don't think we can biopsy that, and I think it may be non-specific nodule. It's only 4 millimeter. I won't be worried about a nodule unless it's more than 6 millimeter or 1 centimeter. So I'm thinking this might be a presentation of cardiomyopathy secondary to his cocaine use, but I'm not entirely sure. We'll see.
Anusha, I think, again, your discussion was absolutely fabulous, and I completely agree with you, right? The center of gravity of this case has now sort of focused on what is the etiology of this young gentleman's new cardiomyopathy. And I think you walked us through an excellent differential diagnosis there. And then I think the question is, well, gosh, if the cardiomyopathy has become the center of gravity, can we explain all of the other symptoms that this patient has from the cardiomyopathy alone, right? The things that brought him into the hospital are things like the hemoptisis, which I will say, that certainly heart failure can cause hemoptisis, or sort of that frothy pink sputum from pulmonary edema. But one thing that I'm a little bit confused by here is that usually patients who have that degree, or usually patients who have hemoptisis from pulmonary edema, we would expect to see a substantial amount of pulmonary edema on CT imaging, right? And we don't see the classic pattern of cross-sectional imaging of pulmonary edema here, right? It seems like this imaging is actually a little bit patchy. We have some peribronchovascular opacities, but it's not necessarily diffuse the way it is in large volume pulmonary edema. And then we also have some nodules here. And so one thing that I think is tricky for me is the fact that we seem to have hemoptisis out of proportion to the degree of pulmonary of pulmonary edema. I think that's one thing. The other thing is the hepatomegaly that you mentioned, which I think is a great point to pick up on. Is this all related to a congestive hepatopathy, or are we dealing with a disorder that affects the heart and the liver together? And then the other piece of information that I think is also, that I'm at least intrigued by, is the presence of the hilar lymphadenopathy. I believe it was hilar lymphadenopathy. Is that right? And so I think
mild mediastinal and right hilar lymphadenopathy.
Great. And so I will say, I have seen patients who are volume overloaded, and the lymphatic system picks up the pace and will absorb the extra volume and can end up becoming volume overloaded. So I think the lymphadenopathy is potentially explained by the patient just having heart failure and the pulmonary lymphatics absorbing pulmonary edema as a compensatory response. However, I think that's something that ends up being a diagnosis of exclusion. And so I think that our pretest probability, common things being common, is exactly as you said. This is a young gentleman who has new heart failure with many risk factors for developing heart failure. And I would say a potentially lower probability, but something that I think potentially warrants at least consideration here is rather than this being a heart problem that has gone, or that has led to complications elsewhere in the body, is there a problem that affects multiple parts of the body, something like the heart, the liver, and the lymphatic system? And if I were to say to something like pulmonary findings, mediastinal lymphadenopathy, and cardiac disease, one diagnosis that potentially comes to mind is sarcoidosis here, exactly as you just said, right? And if we think about things that can cause young patients to have heart failure, certainly drugs, infections, but then also autoimmune or potentially auto-inflammatory diseases can do it too. And I had a patient my intern year who ended up getting a full workup for sarcoidosis because he had similar findings: severe cardiomyopathy, mediastinal lymphadenopathy, hepatomegaly. And guess what? He just ended up having regular run-of-the-mill heart failure from coronary artery disease, right? So these diseases, new onset heart failure from a common cause and sarcoid, can mimic each other. But the gentleman's age and these pulmonary findings, I think, stand out to me as things that are maybe that maybe can't fully be explained by a cardiomyopathy alone. So then the question is, well, gosh, can sarcoid explain this patient's CT chest findings potentially? And the answer to that is probably yes and probably no, because sarcoid can cause so many different findings in the chest. Classically, we might see something like perilymphatic nodules, which is sort of nodules in a linear distribution along the lymphatic areas of the lung, and oftentimes they involve the pleura. But we can see a whole host of other findings around alongside that. You can see ground glass opacities, and oftentimes these will involve the peribronchovascular area as well. And so I think that these imaging findings aren't necessarily incompatible with sarcoid, but again, base rate of disease, still we have to prioritize everything you said, a toxin-induced cardiomyopathy, given the risk factors with the cocaine use, and potentially because maybe the signal here for an autoinflammatory disease has crossed our threshold to at least consider sarcoidosis. But if that workup ends up being unrevealing, then I think we certainly do have a plausible explanation with the toxin exposure here. But I would at least be curious to pursue that diagnostic route. So I'm excited to see what type of information Gerline has for us.
Yeah, so some other labs, so ANA, C-ANCA, P-ANCA were all negative. C4 was within normal limits. Urine, Legionella urine antigen PCR culture were negative. Mycoplasma PCR was negative. Respiratory viral panel was negative. Blood cultures were negative. Sputum culture showed normal respiratory flora. He had a negative quantiferon, and AFB culture and smear later came back negative as well. He also had sarcoidosis rule out, so different tests like calcium was normal, vitamin D 125 was normal, ACE was also within normal limits. So do you just want me to say the final diagnosis? Because I think you've basically come to it. That was the information I had. So the final diagnosis, as you were all discussing, was kind of rule out the other things that could be causing the cardiomyopathy and the symptoms. So we had the pulmonology team also looked at the findings, the CT scan, and looked at the images again, and they thought that the imaging findings were more consistent with drug-induced lung injury secondary to cocaine use or crack lung in the setting of the dilated cardiomyopathy being either secondary to cocaine or alcohol use. So obviously, like infection, rheumatologic panel, sarcoid, all those things needed to be ruled out, and you can't really you can't really rule out ischemic causes of cardiomyopathy without outpatient evaluation for ischemia. And there was also like possible concerns that he might still have some infectious etiology, despite the pulmonology team thinking it was mostly related to cocaine use. So he was discharged on moxifloxacin, but was ultimately said to just follow up with cardiology for ischemic evaluation outpatient, and the preliminary diagnosis was drug-induced lung injury due to cocaine, and then the heart failure being either due to the alcohol or the cocaine use. So I guess some of the things that I was just looking up was that hemoptisis has been reported in around 6 to 26% of people who use cocaine, and it's considered either to be secondary to rupture of bronchial or tracheal blood vessels, or to be parenchymal in origin because of injury to the alveolar capillary membrane. And the term crack lung refers to this acute pulmonary syndrome that occurs that can be acute after inhalation or also be due to prolonged inflammation. And it's usually associated with hypoxemia, hemoptysis, respiratory failure, and diffuse alveolar infiltrates. And the most consistent imaging is usually more diffuse interstitial and alveolar parenchymal opacities that can affect multiple lobes. And they often involve the parahilar regions. So yeah, that's all I had. I think it was very interesting to hear the whole discussion. I learned a lot.
Amazing, Gerline. Thank you so much. That was an absolutely fantastic case, and I want to say I really appreciate your use of a new term for what was formerly referred to as crack lung. I think evolving our language to reflect what the disease course is, rather than potentially stigmatizing language, because crack lung has its roots, at least in the United States, with an epidemic of drug use throughout the country, which was a byproduct of many different sociocultural disparities and racism within America. And so for many patients, that using that language can be stigmatizing for them, and the use of that language as a disease process can also further promote the stigmatization, whether it's in the medical record or amongst clinical teams. And so I just want to highlight the fact that you use the term drug-induced drug-induced lung injury as a way to sort of to encapsulate the fact that many patients may have a similar clinical syndrome who don't use crack cocaine. And I think the continued use, right, in terms of the words that we use to talk about cases impacts the way that we think, the stories that we end up telling about patients. And so I just want to applaud you for at least including the traditional term for those who may not be familiar with the new term, and also continuing to move us forward in the type of language we use to talk about patients by including drug-induced lung injury. So thank you so much for that. Anusha and Sharda, I would love to hear from the two of you, kind of any reflections on this case before we turn it over to Kiara for some of the teaching points.
So here we can see that in his drug use or the social history, he never told us that he uses any IV drug use or recreational drug use. So sometimes it's important to ask the patient when there is no one in the room, because patients doesn't open up in the when there is some family member. So I remember this patient who was like 17-year-old. Sorry, not 17. I don't see patients who are 17, sorry, 18 or something like that. So who is like around 18, 19-year-old. And his girlfriend was there in the room when I went to see him, and it was on night float. So she was there. So I asked him about vaping and he said no. I asked him about the drug use and he said no. And surprisingly, in the morning, to the morning team, when he was alone, he said that he does vaping, and that too daily. I'm like wondered, and I was like, okay, this is not what he told me. So it's always important to ask the patient like when they are alone as well about the drug history, if you suspect there is a drug history component going on, especially in patients with infective endocarditis, in a young patient with infective endocarditis, or in a young patient whose UDS was positive. UDS is positive, basically.
I appreciate that reflection very much.
Yeah, because I fell into that trap, and I don't think it's a trap, but it's always important to think about it in the back of the mind that patients might not feel comfortable when there is a family member or when there is a significant other to share such things. And I had similar experiences with my patients in the last 3 years. Like they don't also tell some of the psychiatric history as well. They won't be comfortable telling those because there is always a cultural difference, and also there is always a stigma in the cultures as well. So it's always important to keep that in mind. And I would say that there are so many times where I went back and asked the patient about the history after looking at some of the results. Some of the lab results or some of the imaging findings. I went back and asked the patient, okay, do you do this? Or can I ask you something? Because it's not only like when you take the history on the first day itself that you have to get the whole history. You can go back and ask the patient based on what your differential diagnosis changes on a daily basis as well. That is what I thought of telling.
Yeah, no, thank you. Thank you so much for sharing that, Anush. I think it's a really important reminder of the fact that our ability to reason effectively through a case is as much of a byproduct of the schemas that we hold in our brain as it is of an ability to build trust with the patients who we care for. And I think it can be very, very easy to, and I have certainly felt these emotions that I feel entitled to certain amounts of information because patients are coming to the hospital and I'm hoping to gather that information to help solve a problem of theirs, and to always remind ourselves that the things that we feel like are necessary to make a diagnosis may be things that individuals hold incredibly personal to themselves, or things that are very, very private to them, or fundamental parts of their identity that they may not be comfortable sharing with us. And so I think I appreciate your reminder to maintain humility and focus on building trust. And if patients don't reveal certain information to us, that's never their fault because their health history is their own. It's our fault for not creating the environment in which they feel comfortable sharing. Charlotte, any reflections from you for as another discussant in the lukewarm seat with us today?
Yeah, I think this case was very interesting in that in some ways, sort of starting at the beginning with a very sort of bread and butter problem of shortness of breath, and thinking about the different ways in which we can put a picture together. I felt quite convinced that there were a few different things going on, or whenever I see something that's happening in multiple systems, I always think of something like, oh, could it be an autoimmune disease? Could it be a malignancy or something like that? So this was just a really interesting reminder to me that something that I had thought of, like drug-induced cardiomyopathy, as being sort of confined to one system, can actually have effects sort of outside of what we're told in school. So that was interesting to see, and I appreciated the opportunity to see you all work through it at like what seemed to me like warp speed. I'm still like, what's the normal lab value? Yeah, so thank you.
Well, you did a wonderful job. It was a joy to hear you think out loud through the case, and I think that your take-home point is the same exact one that I had, to remind ourselves not only what types of, or what the end organs that certain toxins may impact are, but also recognize that they may impact organs that they pass through along the way. In this case, like the pulmonary system. So thank you both so much. I'm going to turn it over to Kiara for some final teaching points to bring us home for the day.
Hey, Gurleen, amazing case. I love today's case, especially because it's cardio related. So we started with a patient, a young patient with hemoptisis, and maybe the big concern is hemoptisis because maybe this patient is unstable. So the schema or how you approach hemoptisis was like based organ approach. First, we have to think about common causes like lung causes, maybe upper respiratory tract like bronchitis or any foreign body that can be there, or lower respiratory tract like bronchiectasis, cystic fibrosis, fistulas, or parenchyma, or maybe this patient with some kind of alpha-1 antitrypsin disorder. Also, with lower respiratory infections can be here TB, fungal infections, especially if this patient was immunocompromised. Some malignancies like vasculitis or, in this example, Gutt-Pasteur lupus. And another cause, less frequently than lung causes, is heart diseases like congenital rheumatic fever, endocarditis, or some vascular malformation leading to heart failure. Or also heart failure can produce hemoptysis if it is due to pulmonary edema, but we have to think about the amount or the volume of hemoptysis if this correlates with this heart failure due to pulmonary edema. Also, some other causes of hemoptysis can be coagulation leading to bleeding, and some mimickers. We also have to ask the patient if he is having really hemoptysis, because maybe this is like nose bleeding or GI bleeding preceded with vomit. So we have to assess this patient very carefully. After that, the question is how we can move forward, and we have to assess the background of the patient, because this patient has a very big concern for HIV or being immunocompromised and thinking about infectious diseases. Also, we have to think about if this patient was born in another country, we are thinking about TB or other fungal or disseminated fungal infections. Also, this patient has had chest pain. Chest pain we can focus that in the heart or in the lung, but as this patient had orthopnea, we were focused most on the heart at first. Also, we were concerned about this patient if maybe it had endocarditis because it had a recent dental abscess. So I thought it wasn't some kind of endocarditis, and I was almost completely sure. And Anne-Marie told us that around 80% of patients with endocarditis has you can hear a murmur, and in this case you couldn't hear a murmur, so this was like a fair diagnosis then. Then you will notice that this patient had like systemic concerns or symptoms, but it wasn't correlated with laboratory exams because laboratory exams didn't show any kind of inflammation. So when you see these both things, you can think about some immunocompromised patients. So how can this be thinking? One infection surrounding the heart, or maybe a myxoma or endocarditis due to some other, maybe this patient was predisposed to some endocarditis, carcinoid syndrome, HIV, TB. Hopefully all these labs were negative. And lastly, two more things. This patient had ground glass opacity. So what can cause ground glass opacity? Maybe cardiac diseases like over volume patients or pneumocystis, Hirobashi infection, but this goes most with immunocompromised patients, and also COVID-19, and this patient was negative again for COVID-19. And lastly, ileal lymphadenopathy. So most common causes of ileal lymphadenopathy can be explained by volume overload, but this is like an exclusion diagnosis. You have to rule out others first. So maybe as this patient had liver, cardiac, and lung compromise, you all think about sarcoid because sarcoid can present first as perilymphatic nodules, but less common can present as ground glass opacity as this patient. So finally, the diagnosis was like drug-induced lung injury due to cocaine. And this is the first case I see about this, and I love the case. I love the discussion and also the reflections, because at least in Peru, we have many patients with different cultural backgrounds, and it's also hard to assess a family or social history too.
Amazing, Kiara. Thank you so much for sharing those. And thank you everybody for joining us for another edition of VMR. This was an absolute blast as always. I'm very grateful to Gerline for bringing a phenomenal case that was very well prepared and thoughtful as they always are from you. And a huge thank you to Sharla for stepping up into the lukewarm seat, and for Anusha volunteering what was a very experienced discussion here. So thank you so much. This was an absolute blast, and we look forward to seeing you tomorrow for another edition of Virtual Morning Report. Hope you all have a great whatever time of the day it is for you, and we will hope to see you next time. Take care, everyone. See ya.